You can almost teach anybody to do surgery, but to select the right patient for the right treatment and to follow up, it demands continuity and to be there when the patients are there.
Well, we're back now in our studio to discuss a challenging issue in urology. We're looking at when things go wrong. Gentlemen, thank you both for joining us. Bertie, I wonder if we can start with you. You're a medical lawyer. Can you give us an example of when things do go wrong?
We've just done a session in which we looked at 3 specific cases. One was a generic problem, which is when urologists fit a stent, very often for other specialties, and then it gets forgotten. And it's left until it's encrusted, and then it's very complicated to get it out, and sometimes things go very badly. Another was where they failed to recognize that a patient had developed sepsis. But all of these are cases where people are trying to do something very specific. They're very highly trained to do a simple job. And in retrospect, when you go back over it, you can see that there were things that they should have done either in the imaging or the infection screening or the prophylactic antibiotics, whatever it is. But above all, what I think is most important about this is that people fail to recognize the deteriorating patient.
From the medical perspective, why are people failing to recognize that?
We fail to define the patients who are at risk. At least that's very important, even before we do our treatments. Of course, we as urologists, we want to heal our patients. We want to do good. And when things go wrong, it affects us tremendously. Recognizing when it goes wrong at a very early stage, but also initially defining patient at risk. That's very important.
Would either of you say that the way that the medical profession is organized has any impact on this?
Doctors are now very highly trained to do specific interventions, to do specific procedures, and 90% of the time it works very well. Because of the way in which medicine is structured, with shorter working times, with patients in the hospital for much shorter periods, doctors have, when they're in training, very short interventions, and the trainee is just there as a fleeting acquaintance who comes in to do a specific job. And when they are complicated, they meet them for the first time after they've had a complication. And then those patients mostly do well as well, because the complication is skillfully handled by the consultant and the trainee is a spectator.
Technological development has moved tremendously forward in our specialty. We are doing more and more procedures, minimal invasive, and many of the procedures, it can be done as a single surgeon. When I was trained many years ago, we were assistants to the seniors and seeing the procedures many times. For the sake of productivity, the younger doctors are put in another place in the organization to earn their money.
So the younger doctors aren't gaining the experience that they maybe would have done a generation or so?
Certainly, and it's partly because we're more risk averse. We don't allow juniors to do things.
Pal, what do you think we can do to rectify this?
You can almost teach anybody to do surgery, but to select the right patient for the right treatment and to follow up, it demands continuity and to be there when the patients are there.
And more rules. That's what the cases we were talking about this morning were about the rules that there are to protect the doctor and the patient.
Great. Well, thank you both for joining us. Obviously, we could talk about this for all day, I think, but have a great rest of your Congress, and thank you for joining us.
Thank you.
EAU TV is brought to you from the 34th Annual EAU Congress in Barcelona. And if you'd like to watch more things like this, then you can click on these videos here. And you can also subscribe for the very best in medicine, from psychology to urology, from gynecology to genetics.